Hi, everyone, and welcome. My name is Jeremy, and I am a representative of EHM Canada. We are a nationwide network of treatment centers for addiction, trauma, and mental health. We have facilities located in British Columbia, Alberta, Ontario, Quebec, and Nova Scotia. We offer high-quality inpatient, outpatient, and online treatment programs. For more information about us, please visit our website at ehncanada.com. Just in terms of some housekeeping, everyone is on mute and cameras are off for today's webinar, but please feel free to use the Q&A box located at the bottom of your screen to submit any questions for our speaker. We will try to get to as many questions as we can at the end of today's session. Today's webinar is being recorded, and we will be sending out a follow-up email sometime mid to late next week that will include the link to the video and any useful resources as well as your CEU certificate. Just to reiterate, we will be sending out a follow-up email sometime mid to late next week that will include all additional resources. I am located in Toronto. Toronto is located on the traditional territory of several nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. It is covered by Treaty 13 with the Mississauga of the Credit. We also have presence today at our Gateway facility located in Peterborough. Peterborough is located on the treaty and traditional territory of the Mississauga Anishinaabe. If you are new to this work and want to find out whose land you are on or grew up on, please check out native-land.ca. Many more of you may be physically present elsewhere, and I encourage everyone to use the chat function to, where applicable, share whose land you are on. Now to get to today's session, exposure therapy for PTSD and anxiety. We have Shawn Carter. Shawn Carter is a behavioral therapist by background with 16 years of experience working in the field of mental health and social services. He joined Gateway Recovery Center as clinical director, but previously managed patient access and flow in a number of outpatient psychotherapy clinics at Ontario Shore Centre for Mental Health Sciences and led the design and launch of the First Responder Assist program in May of 2020. Shawn is now the executive director of Gateway Recovery Center, offering his expertise and passion for EHM Canada as a network. Please help me welcome Shawn.
Thank you so much, Jeremy, for that very kind introduction. Thank you all for taking the time to. I see the numbers are quite high. I'm really happy to see lots of people here to attend the training and for taking time out of your busy days to join me. I'm excited to speak about exposure therapy for PTSD and anxiety, a topic that's quite near and dear to me. As Jeremy had mentioned, I am the executive director of Gateway and very, very honored to be able to serve those who have served so many. So I'm going to share a little bit more about Gateway Recovery Center as I talk a little bit about how exposure therapy is carried out here, but have become quite passionate for things like high quality and evidence-based care, serving unique populations, including those that we serve here at Gateway, which are our military, veterans, first responders, and healthcare workers. Again, groups that have done so many to support those in keeping us safe in the community. I'm going to go through the agenda. So I'm going to be speaking a little bit about exposure therapy, some of the literature around exposure therapy, specifically focusing a little bit more on in vivo exposure therapy. Specifically, there are different types, but that's the one I'm going to focus a little bit more on. Specifically, how we might use in vivo exposure therapy in clinical settings to treat symptoms of PTSD or trauma and anxiety. I'm going to talk about how exposure therapy is carried out here. I think sometimes it's really helpful to see how it's actually carried out in a clinical setting. And then I'm going to reserve some time for questions as well, about 5 to 10 minutes at the end. As Jeremy said, all of these notes will be available. There will be an email, like he said, mid to late next week. So what is exposure therapy? To kind of go into a little bit of context or background, research has shown us that there is a clear association between intense emotions and particular stimuli. For someone with PTSD in particular, that association between an auditory stimuli, for example, like a loud alarm, can be linked very closely with intense anxiety. And typically, an association that leads to that type of intense anxiety diminishes over time. So we know that repeated repeated exposure to a particular stimuli that we might fear or might induce anxiety will eventually sort of reduce that anxiety and reduce that feared response. However, if there is any sort of avoidance behavior that happens or avoidance that happens that sort of allows someone to avoid that stimuli, it really blocks the process of exposure or that diminished fear response over time. And that avoidance can lead to further reinforcement of that learned association, or further reinforcement that is a stimuli that should be feared, and that there's a hopelessness that comes with that, which really kind of reinforces those avoidant behaviors, because they do allow the person to avoid having to be exposed to those elements or those stimuli in the environment that might lead to that fear response. So it in a lot of ways it feels good to avoid and obviously to avoid those feared stimuli. So essentially, exposure therapy seeks to combat this avoidance and that learned association. So there's kind of three ways that the literature kind of divides exposure therapy. One is kind of the three main components of exposure therapy. So a lot of the types that are mentioned on the right side of the screen there include all of these components. But those three components are psychoeducation. I'm going to give a little bit more information later on about what that psychoeducation looks like. There's the exposure sessions themselves. Again, going to give a lot more detail about that. And then an emotional processing that happens before, during, and after those exposure sessions. Typically, the types of exposure therapy that the literature speaks to and that are used in clinical settings are imaginal exposure, virtual reality exposure, interoceptive exposure, and in vivo exposure. And for the purposes of today, I'm going to be focusing on in vivo exposure, which is found to be sort of the one of those with kind of the most evidence to support it, especially in clinical settings like the one I work in, which I might not have mentioned at the beginning, is a residential inpatient facility where we have the privilege and ability to be in the community doing these actual in vivo exposure sessions. The literature also speaks to exposure therapy pace and usually breaks that down into three different examples or three different types or versions of pace. So one is graded exposure, flooding, and systematic desensitization as well. And the graded exposure one is the one, again, that I'll be focusing a little bit more on today. So why exposure therapy? And I think I've maybe spoken to this a little bit, so I won't spend too much time here. But like I said, it aids in confronting those fears and triggering stimuli. It decreases avoidance of objects, activities, situations, or environments. And what we know is that avoidance then impacts people's ability to live their lives, to be out in the community, to be able to potentially go to work, have meaningful social connections, engage meaningfully with the community. So exposure therapy can definitely sort of facilitate that re-engagement in those meaningful activities. It reduces the impact of trauma and anxiety related symptoms on a daily on those daily kind of occupations that are important to folks and the activities that were once meaningful to them. Supports approaching feared and avoided stimuli, of course, helps build coping skills and mastery and hope. But in a lot of ways, also supports things, very practical things like the ability to return to work, knowing that often for the folks, well, for almost all of the folks that we support here at Gateway Recovery Center, they are folks who've been exposed to traumatic experiences in workplace environments, whether that be in combat overseas, in the reserves, or in their actual day-to-day work as a first responder or a healthcare worker. So there's a very practical implication of doing exposure therapy on actual stimuli they may have to experience when they return to work. And like I mentioned, can be incredibly empowering as it instills hope and mastery, because many people for years and years avoid those stimuli. So in vivo exposure therapy specifically involves clients engaging in activities in real time. So they're actually in the moment being exposed to those stimuli. Again, I'm going to describe how that happens in a very safe and planful way. But that gradual approach to trauma-related, it could be memories, feelings, situations that are usually avoided because of those traumatic experiences. Part of that includes a fear hierarchy of those actual avoided activities that help guide those in vivo exposures. So identifying specifically what are the least to most distressing sort of stimuli that might exist in an environment allows us to build a hierarchy that can safely move people from step to step. The three categories of in vivo exposure, as per the literature, include exposure to situations, Could be activities, could be objects in particular that are avoided due to those fears regarding safety. Exposure to situations or cues that are avoided because they are triggering or reminders of that particular trauma. And also a behavioral activation component, which again, I'm going to speak to more as we go on. So safety behaviors are an incredibly important aspect to consider during in vivo exposure because those safety behaviors can prevent clients from learning what their window of tolerance is for avoided situations. And I'm going to speak to window of tolerance in a little bit more detail. In general terms, it's the case that the brain is functioning well and can effectively sort of process the environment around them or the stimuli around them and can think rationally and make decisions calmly. And each individual's sort of window of tolerance is very different and individualized. But for those who experience PTSD or anxiety, mostly unconsciously have a more narrowed window of tolerance. And that creates a sense of safety because if I'm not exposed to the things I fear, then I feel safer. So it creates a sense of safety, and that's how some of those safety behaviors emerge, like avoidance being sort of an actual behavior that can occur when there are those fears of those stimuli in the community, for example. So I'm going to give a quick example of fear activation. So under management of, so I'm going to go back a slide here. Under management is more common than over engagement. Under engagement is more common than over engagement during in vivo exposures. And that's linked to avoidance of the actual adverse emotions and thoughts associated with that stimuli. So fear activation must occur for the in vivo exposure to be effective. So we have to actually have them come into contact with a version of that stimuli. Doesn't always have to be that particular thing itself. Sometimes it's just actually talking about that feared stimuli as one of those low steps on that fear hierarchy. But that without actually facing it or talking about it or being exposed to stimuli that are even reminders of that particular trigger, changing that association between the stimuli and emotions cannot occur. So there's a common sort of PTSD analogy that's used, and it's the linen closet analogy. And I'm going to share what that analogy is and then go one step further in how it applies, you could consider it to kind of apply to exposure therapy. So memories with PTSD can often be compared to, and in this analogy, are compared to kind of linens and towels that are kind of stuffed into a messy closet. I'm going to go back to this image, that are kind of stuffed into a messy closet, like a linen closet. In that analogy, when you walk by the closet too quickly, or you brush up against something, or you pull something out, sometimes what happens is that a lot of items actually fall out of that closet. And that's likened to a lot of kind of the symptoms you might see when someone is struggling with PTSD. And the idea with PTSD treatment is that you find ways to process the traumatic events. So treat each little towel that falls out of there, and take things out of that closet and examine them carefully, fold them back up neatly, and then put them back kind of in their right place. And that's done by very skilled professionals using multiple sort of modes of trauma processing therapies. But to take that kind of one step further, if when those towels fall out of that closet and hit the ground, and the linens fall out of there, and we're not paying attention to them, and if we're just avoiding them, what happens is that those linens and the towels just kind of build up to the point where maybe it actually prevents you from being able to use that closet at all, be able to walk through that hallway, use the room that closet is in. So there has to be a way that you can kind of reapproach those stimuli to be able to be in the midst of those triggering stimuli in the community. So exposure therapy has a high rate of success when used to treat anxiety and trauma-related mental health concerns, including in treatment of PTSD. This is what the literature tells us. In the treatment of phobias, in the treatment of panic disorder, agoraphobia, in the treatment of obsessive compulsive disorder, along with response prevention, as well as generalized anxiety disorder. In vivo exposure is also linked to changes in PTSD symptoms, more so than actual imaginal exposure techniques. Both can be effective in certain cases. We find in our clinical experience that imaginal is often a really great way to sort of build success before you actually get to the in vivo exposures, when there's a very intense fear associated with a particular stimuli. It's possible that continued implementation of in vivo exposure, there may be longer term changes associated with those distress symptoms as well. So before I speak to how we at Gateway Recovery Center use in vivo exposure therapy, I think it's important that I spend some time talking about our center, just so that you can kind of get a context for how this sort of plays out in the day-to-day. For any of the clinicians in the training today, I find that that's a very, to think of it in practical terms of how it could be potentially implemented, I think is really helpful. But also if you're someone with lived experience and you're here just interested in learning about exposure therapy or about PTSD, it could be a helpful way to kind of know what types of treatments are out there. So providing that context, I think, is important. So Gateway, to our knowledge, is the first and only state-of-the-art facility in Canada that's exclusively dedicated to first responders, military personnel, and healthcare workers. Not that there are not many other treatment providers serving this population, but none to our knowledge that exclusively serve this population. Including across the EHN, we serve many first responders at many of our sites across the country, including Edgewood Health Network, and on one end of the country, like Jeremy mentioned, all the way to our Atlantic Center for Trauma out on the East Coast, all doing amazing work, very similar to the work we're doing. Ours do not have any other people who from other populations who receive treatment in our particular center. All of our programming builds on Bellwood's 30-year history of specialized programs for first responders, substance use disorder, occupational stress injury, and PTSD. We still consider ourselves fairly new, so we opened in July of 2021. We serve those 18 and over, those who identify as male and female or otherwise. We have semi-private rooms available. Each room has a separate living and sort of study space in the middle. The building has access to a gym, yoga, meditation, lots of games happen kind of in that room you see in the one picture, and a dining room with an attached lounge. And I always like to sort of stress the importance of that sort of community feel. And it's what we really try to kind of emphasize in this case, knowing the camaraderie and connection that people form when working in their particular safety personnel related positions. So we're located 1 kilometer outside of Peterborough. We're on 14 acres of land and walking trails that they're often using. A client of ours actually took this wonderful drone shot, which doesn't even begin to cover all the walking trails. We have a 22,000 square foot facility that's divided into 2 buildings. We also border a golf course, which we have a great relationship with. There's a multi-sports court you can see there in the picture as well, with a fully equipped gym. We do welcome service animals and actually really encourage our staff to bring our dogs, which brings me to a totally shameless plug of my dog, Stanley. He's here often. He's not here today, but he's here 1 to 2 days a week in the TENS groups. And we really kind of recognize the importance of having animals here. And funny enough, Stanley's actually taken part in some exposure hierarchies himself, given that some people sometimes have experienced traumas related to animals in particular. So Stanley will sometimes be found either providing emotional support in vehicles when people are out doing exposures, or supporting them here on site, but also can sometimes actually be part of that exposure hierarchy. We treat, again, public safety personnel, so firefighters, correctional officers, police officers, emergency dispatch, paramedics, border service personnel, RCMP, search and rescue personnel, active military members and veterans, and frontline healthcare workers. So our team at Gateway is made up of highly skilled and dedicated clinicians, which include social workers, registered psychotherapists, occupational therapists, physicians and nurse practitioners, nurses, recreation therapists, addiction counselors, wellness practitioners, executive chefs, and a whole host of incredible non-clinical staff as well. Our exposure therapy in particular is carried out by our social workers, registered psychotherapists, and occupational therapists. However, the treatment itself is provided by members of our entire team. The exposure program at Gateway isn't something that's considered to be mandatory, but highly encouraged for our clients that come through our program. And the program of exposure therapy in particular involves an intro to exposures group, which I'm going to spend a bit of time kind of discussing what topics are included in that group. There's also an exposure team meeting, which following that exposure group, the members involved in sort of the exposure, the delivery of exposure therapy, meet to kind of, assign people to the individual exposure therapy roles and identify who might be good candidates for exposure therapy. And then in the actual individual exposure sessions themselves, they're divided into a planning session where things like the fear hierarchy are identified. Again, I'm going to go into more detail about that. And a plan for sort of when will we do this? What are the strategies we're going to kind of employ? All those sorts of things. Exposure sessions themselves actually happen again in the community or here on site. And then discharge planning in terms of how are we going to use the things that we've learned and the strategies that we've acquired by doing exposure therapy when we leave this type of intensive treatment. So typically this occurs, so the actual exposure group itself occurs during week 2 of treatment. So we give them a chance to kind of identify some sort of a foundation of coping strategies before they start to learn this, but they learn about things like the fight, flight, freeze, fawn responses that are common in PTSD, identifying natural kind of tendencies and emotional responses when faced with feared stimuli. Explanation of what exposure therapy is, so things like how exposure therapy can aid with PTSD and anxiety, much like I was able to share at the beginning of this webinar. How the exposure therapy process itself works and what's sort of the rationale behind why we do it that way. The use of subjective units of distress scale or SUDS in identifying signs and warning signs, and then the associated skills that might go along with those identified warning signs or signs. Discussion regarding avoidance and how avoidance plays a role in things like safety behaviors and PTSD symptoms and anxiety symptoms. We then complete an exposure hierarchy with the individual, which often includes giving them homework, but can actually also be completed with their primary clinician, which is their individual therapist, not necessarily their exposure therapist. I think it's helpful sometimes to see examples. This would just be, this takes many forms, and depending on the type of exposure work we're doing with an individual, whether it's anxiety-based or PTSD, sometimes this looks a little bit different, but this would be an example of an exposure hierarchy. So what we have them do typically is describe in kind of general or broad terms what provokes your anxiety, what are the themes of things that provoke your anxiety. And then we have them list those out, not necessarily in any particular order, just kind of list them. And using that subjective units of distress scale, we have them rate from 0 to 100 how distressing even just the thought of kind of being exposed to that stimuli might make them. And from that is where we generate an exposure hierarchy. We would take the things that are closest to 0, the feared stimuli that produce an emotional response that are closer to 0, all the way up to the ones that are closest to or at 100. So here's an example of an exposure therapy, like what it might look like when it's completed. Again, it might take many different forms. In this case, this is one that's been developed to support someone with symptoms of OCD in particular, which we know is an anxiety disorder. So I'm not going to kind of read through these, but you can see that that the exposure hierarchy has been broken down into 9 particular steps. And you can see that on the right, anticipated SUDS of being exposed to that particular experience or trigger or object or activity is associated with a particular SUDS level. So that SUDS level could be anywhere from, so the first step there looks like the anticipated SUDS would be 40 all the way to the 95 from the using a public restroom and not washing hands after, just that 9th step that you see on your screen there. I'm going to be providing a lot more examples of the types of things we approach, because OCD would just be kind of one example. So in the exposure therapy team meeting, the team of staff who collaborate and provide support to the primary clinicians, who again are the individual therapists doing the individual therapy work in our program. and support the clients through that process. So this occurs during week 3 of treatment after the clients have been exposed to the exposure therapy group. We review exposure session progress. So any clients who are in the midst of actually completing exposure therapy, who've already had some sessions, progress is discussed. It's a great sort of way to have, and we employ kind of a consultative model where they're supporting each other, the therapists themselves, with how they're going to best deliver exposure therapy. If there's any snags in that process, if someone's really not progressing or there needs to be changes made, this is where those discussions would happen. We review client exposure needs, so important to identify each client's goals, kind of their comfort level, and specifically that exposure hierarchy, like I spoke to. Trauma-based exposures are to be completed with people's primary clinicians, so they're the ones from that exposure team that are the ones delivering it. Things that are more, and we kind of employ exposure methods, I guess, not so much exposure therapy, to other things like just community reintegration. Sometimes it's not a particular stimuli, it's just the avoidance of the community as a whole sometimes, or it's exposure to things for people, for example, who struggle, let's say, with substance use disorder or alcohol use disorder. Things like the liquor store can be incredibly challenging to even drive by or walk by. So where that might be something that could be done potentially with someone like a recreation therapist or another therapist, where there isn't sort of the psychotherapy kind of element of the exposure therapy involved, where we're very cautious about who's delivering which type of exposure-based modality. So the individual exposure sessions themselves happen after the exposure planning meeting and occur during week 4 of treatment. Typically, people are with us for 7 to 9 weeks, just to sort of anchor that timing. They review an exposure hierarchy completed in the group session or as homework. They review the role of avoidance and why they've been avoiding, what are the things that have led to them or reinforced that avoidance. We review the importance of gradual exposures, and because a lot of them will come in thinking, oh gosh, you're just going to sort of flood me with these feared objects or experiences, and we're very careful to bust that myth and allow them to realize that we're going to use coping strategies and do it in a very gradual way. We review what clients' distress actually looks like so that we can be prepared for how we're going to employ certain strategies in the community should it lead to more distress than is expected, or even just that we expect that it will lead to distress. We plan that exposure hierarchy and actually book the first session in that first planning session. So the individual actual exposure sessions themselves then happen. So what happens is you would take time to review the pre-exposure homework where they're kind of identifying what strategies they're going to use, identifying what step on that hierarchy they're currently at. They check in about the actual subjective units of distress or SUDs before, during, and after. So the idea is that, okay, let's identify sort of how you're feeling right now in terms of your subjective level of distress. That happens also during the actual exposure itself, often multiple times, and then after the exposure also. And there's a couple reasons for that. One is so that the therapist can identify specifically where are you at, what kind of strategy should we be employing right now to support you through this, but after as well, because often there's this idea before they even start this type of work that they maybe feel like they're not actually able to do this at all, and it serves to sort of challenge that by saying, like, you expected you'd feel like this, you expected that this particular trigger, for example, would lead to a SUDS rating of like 85, let's say, and oftentimes what they find is in a supported kind of controlled way of being exposed to those stimuli, that perhaps that's actually lower than what they expected, and demonstrating that after those exposures they can actually use the strategies to help them kind of reduce that level of distress afterwards as well. We use a lot of outcome measurements, including things like we use the PCL-5 specifically as sort of a measure of PTSD symptoms, but really kind of use those outcome measures to kind of identify whether these types of interventions are helping to reduce that symptomology and their ability to kind of function independently and in the community. We remind the client of coping skills that they're able to use. I'm going to give you kind of an example of how that's kind of worked into a particular example. Remind clients that they're safe during the exposure. That reassurance is a huge component, that it can feel again, they've developed these safety behaviors because their PTSD, their traumatic experiences, their anxiety tells them that being in the presence of those stimuli is an unsafe place to be. And so that reassurance is incredibly helpful to know that, and often it's as simple as, I am here with you, everything is okay, we will get through this. Also, things like avoiding the use of distraction. Often the distraction itself has been used as an avoidance strategy in many cases. And while there are particular clinical sort of situations where distraction can be helpful, in this particular case, we actually encourage them to feel those emotions, because in reality, that's what's going to happen when they're on their own and in a less supportive environment. You can also think that it can be considered as avoidance of the trigger, which negates the effectiveness of exposure itself. So this is sort of, again, an example, and it's not the full sort of SUD scale. I'm just sort of using an example of kind of some of the higher ratings of the SUD scale. But essentially, this is sort of like a worksheet that's often completed, or even kind of a homework assignment where it's identified that, okay, if I'm feeling in the 90 sort of range of SUDs, where I'm feeling incredibly distressed and I almost feel completely out of control, what are the thoughts, behaviors, or physical changes that I'm going to notice to know that I'm in that range? And then also, probably the most important part is, what are the distress tolerance skills that I'm going to use to manage that high level of distress? And of course, that there'd be different strategies that we'd use depending on the particular SUDS scale, or where they're at kind of on there. And again, this is often used as a homework assignment, and it's reviewed before actually going out on those exposures, so that both the therapist and the client can be on the same page. So I'm going to review a case study, and this one particularly relates to PTSD, and it's someone we've named Andrew. And again, this is just a hypothetical example. Andrew is a 54-year-old police officer who's on a leave through WSIB. Again, we serve people who are funded through WSIB, through the Canadian Armed Forces, through Veterans Affairs, through the RCMP. But this particular gentleman in this example is on a leave through WSIB due to PTSD symptoms specifically. He was involved in a traumatic event involving a vehicle collision with his police cruiser. He suffered from minor injuries. However, part of the vehicle pileup on the highway that did result in a fatality. Andrew was not in any way at fault for the actual collision as the police officer, but did feel immense shame and guilt following the event, which is often a very common response to traumatic exposure to traumatic events in these types of professions. Andrew began avoiding driving on the highway when he could. However, this began to really impact his ability to perform his daily duties as an officer. Which led to him having to go off work ultimately. His wife does drive him places, however, insists on avoiding main roads or will refuse to leave his home many times. Currently, Andrew does not drive due to fear for his safety and the safety of others on the road. Andrew began with psychoeducation regarding exposure therapy. So this is sort of how this would play out in this hypothetical example. So he would begin with psychoeducational sessions regarding exposure therapy. Again, the goal of exposure therapy being to diminish that association between the stimuli, which is driving in this case, and the emotional response, which is fear for safety, which ultimately leads to avoidance, which ultimately has impacts on his social, emotional, and even occupational well-being. In sessions, Andrew and his therapist would explore the traumatic event and discuss the impact of avoidance. The Intro to Exposure group itself would also aid in teaching about avoidance and the benefits of exposure, like I mentioned before. He would complete a fear hierarchy with one of those trained professionals, like I mentioned, one of those therapists, to help guide the exposure work. And although distress is indicated, it's important to note that this can change throughout the exposure experience. So what we find is when we revisit those SUDs later on, we find that those same stimuli that elicited, or at least it was anticipated would elicit the highest levels of distress, often actually reduce significantly, and gives both the client and the therapist evidence that this intervention is actually working. So in this case, his particular exposure hierarchy, I think it's helpful to see an example. would include what you see here. So the feared situation in this case would be driving on back roads or other vehicles. Again, in this case, in our kind of setting, we don't allow clients to actually drive vehicles, especially it likely wouldn't be safe in this case if part of the fear is the driving itself. We'd be afraid the distress would lead to an unsafe situation in that case. But being on roads with one of our staff driving one of our company vehicles, would be driving on back roads with other vehicles where they've anticipated that distress will be 25. The next would be driving through main roads in town with other vehicles around, which was rated as 35. Being stuck in traffic on main roads in town with vehicles would be 45. I think you kind of get the idea that you can sort of break down this hierarchy in as little or many steps as possible, understanding that in our setting, at least, we only have a certain amount of time to work through these. So often what happens is we identify that there may be opportunities for them to kind of target some of these exposure stimuli once they sort of are doing really well with the lower ones, that they could actually kind of practice on their own in the community as well. And anyway, would go all the way to driving on a main highway, something like the 401, for example, here in Ontario, our major highway that cuts across Toronto, with traffic weaving in and out, was rated at an 85 SUDS level or distress level. After the exposure team meets to discuss how to implement the exposure therapy, for Andrew, for example, would go on exposures with a therapist using a company vehicle. They would start at least distressing event first and work their way to the most distressing through that hierarchy. He would be asked to rate his SUDS prior to the exposure, during the exposure, and after. And emotional support obviously would be provided throughout the entire process, sometimes before, often before, during, and after the exposure itself. So before I get to the question and answer period, I did want to just provide kind of a list of examples of specific targets that we've supported folks with through the exposure work that we do. So sometimes it's the actual, like, for example, fire or police stations or EMS stations or paramedic stations specifically. It could be emergency vehicles themselves. It could be things like sirens. It could be grocery stores. It could be crowded places. It could be specifically social exposure, specific social sort of situations. Like I mentioned before, it's not always necessarily PTSD or anxiety related, but could also be things like the site of liquor stores or places that serve alcohol, for example. It could be animals. We've supported folks with exposure to their actual home or community environment where potentially a traumatic event happened. It could be the site of uniforms. So some of our military members, for example, really struggle with the sight of military fatigues. So that could be potentially part, or even just the sight of things like camouflage, that sort of pattern on clothing. Things like highways we've supported with, sometimes downtown areas in small towns or busy city centers. Could be cafes or particular restaurants, things like fireworks or sudden loud noises, sometimes the sight of a weapon for where a weapon's been involved in someone's traumatic experience. Sometimes it's things like cultural symbols, depending on maybe where someone's maybe served in the military. Could be the sight or sound of babies or children playing or making loud noises. Sometimes schools, school buses, wooded areas. So obviously, I'm not going to go into detail about maybe why some of this might have come to be as being particularly very feared kind of stimuli for folks, but often these are the types of things that really prevent people from engaging in meaningful activity in their life, whether that be getting back to work, but the impact that avoiding these types of things has on their social, emotional, intimate relationships. There's such a huge impact that avoidance can have on their ability to live their lives in a meaningful and fulfilling way. So I feel like I'm a little bit ahead of schedule, which is fine. It leaves more times for questions. I'm not in any rush to get off, but I will turn it away to Jeremy.
Perfect. Thank you so much, Shawn. And like you said, it's better to have more time for questions than to not. So thank you so much again for that presentation. And we have lots of questions, which is always a good sign. People are engaged and invested, so we can get right to them. There's a question, can you elaborate on the usage of exposure therapy for OCD? I know you spoke to it a little bit, but if you could just expand a little bit, please.
Of course I can. So we don't particularly treat OCD necessarily. It's not that we don't accept people who might be struggling with symptoms of OCD. It's not typically kind of our bread and butter here. We do support with it. I've definitely worked in clinical settings where I've used things like exposure therapy to support folks with OCD. The idea is that there are, while different in nature in terms of maybe what led to the development of OCD symptoms than it would be for like PTSD, for example, but there are often, given OCD is an anxiety disorder, there are still feared sort of stimuli or situations that occur with OCD in particular, and exposure to those stimuli, like sort of the example I provided, where potentially working all the way up to being able to be in a washroom, like use a public restroom, for example, if let's say like germs is the particular sort of area of focus for someone's OCD, that repeated exposure and gradual exposure to those feared stimuli can help break that sort of cycle of avoidance and reinforcement. So I hope that kind of answers it. The additional component that often the evidence will speak to is exposure and response prevention, because sometimes engaging in particular safety behaviors, if we're thinking of it through the lens of kind of PTSD, engaging in those safety behaviors can really prevent someone from being able to access the community in a meaningful way. And it's no different with OCD, where not being able to use a public restroom could have very serious implications on their ability to go to school, or their ability to go to work, or go to some type of social event where public restrooms may be the only option to use. So hopefully that answers the question.
Perfect. Yeah, thank you so much. We do have a question about OHIP coverage for Gateway. So they're just asking if Gateway is covered by OHIP, or treatment like exposure therapy would be covered by OHIP.
So there's certainly settings that can support with some of the symptoms of these types of conditions like PTSD, OCD, anxiety in the community, for sure. We in particular serve a very unique set of people, and the people who refer to us are the Canadian Armed Forces, Veterans Affairs, and WCIB, and the RCMP, who all have funding sort of provided for them to access treatment. So it's in very, very rare circumstances would anyone ever pay out of pocket for a service like ours. However, it is not covered specifically by OHIP. So I'm happy to. I could speak to some of those kind of community providers. I see that when I saw the participants, I see people are coming from all over the place, and I feel like it wouldn't really do it justice if I listed just local resources here. But there are certainly kind of tertiary care mental health hospitals, usually like across the country, that often have outpatient programs that include psychotherapy, include anxiety and mood disorder clinics, include trauma clinics. You mentioned, that I spent a lot of my clinical years and leadership years working at Ontario Shores, who has, for example, a first responder assist program specifically to treat PTSD and mood and anxiety symptoms. But there are many kind of services like that kind of in the community. Encourage people to reach out, especially across Canada, to places like Wounded Warriors, who are excellent resources for folks who fit sort of within that population of first responders. And military and veterans, to reach out to have them potentially connect them with local services in their areas, or actually receive supports through Wounded Warriors themselves. So some of those organizations can be really, really helpful in connecting people with services. But to answer that question, OHIP does not cover treatment in a setting like ours.
Perfect. Thank you so much. And Wounded Warriors will include as an additional resource as well, just for the follow-up emails.
Wonderful.
And then if you want to speak to more of the referral process, like if there is a referral process, like waiting lists, if you want to speak to like a little bit of the logistical end of Gateway.
Sure. So I think part of the context to sort of lay out there is that we do serve folks from across the country. And again, we have EHN as a whole has sites across the country supporting folks. So Gateway is not the only option within our network. I want to make that very clear as well. But our center in particular has 28 beds. So we at most can ever have 28 people within our facility. And again, they're being referred from like the RCMP or WSIB or the Canadian Armed Forces or Veterans Affairs. And we know that this is a huge prevalent issue, which there's been a lot of light sort of shined on these particular populations, mental health in general, of course, and tons of efforts to sort of decrease stigma and everything. But this population in particular has had a light shone on it as of late, which I think is long overdue, and there are more services sort of kind of popping up. But what it does mean is that there are a lot of people looking for this kind of help, and as the stigma decreases and more services are available, you have more people raising their hands and saying, "I need help." So currently, the referral process would be that. The way that it typically works for us is that if someone goes off work, let's say they're a paramedic or an emergency dispatch, like a 911 operator, they go off work as a result of a traumatic event, which they refer to as a psychological injury. If they have a WSIB sort of claim, they would ask to be connected with the First Responder Mental Health Specialty Program, which is a partnership between ourselves, Trillium Health Partners, Ontario Shores, Centre for Mental Health Sciences, and Woodstock Hospital. And they would sort of facilitate access to a variety and spectrum of services across those 4 partners. Wounded Warriors is well connected as sort of a source of education and services through that partnership as well. I forgot to mention that. And then they would likely receive an assessment that would deem, okay, do they need residential treatment, or could they use sort of a high intensity or moderate intensity outpatient program, or would they be best served in the community at a different sort of community provider that might meet their needs? With Canadian Armed Forces, Veterans Affairs, typically there's a case manager assigned when someone's struggling with kind of an occupational stress injury or psychological injury, where the case manager would sort of guide that referral process, and they'd reach out to EHN to start that process. In terms of a wait time, it really fluctuates, from month to month. Typically, people do get in within, say, 1 to 3 months of a referral to our center. Often, though, when people potentially maybe decide not to come here, we're able to kind of bump people up, and sometimes we're able to bump people up based on severity of symptoms or particular case by case scenario. But for the most part, it's sort of a first come, first serve kind of situation.
Perfect. Yeah, thank you so much. And I know you mentioned too, like we are a nationwide network too, obviously you being focused on Gateway, but within these military, veteran, first responder audiences, we do have the Atlantic Center of Trauma located in Nova Scotia. And then we also have our Ferguson building, which is located out of our Edgewood facility in Nanaimo, British Columbia. So as Shawn mentioned too, like when people are contacting EHN admissions or referral process, we do our best to allocate within geographical location, but also putting the disorder or substance use disorder first, and then going from there in terms of placement and location options too.
I'll mention too, sorry, Jeremy, just to sort of add to that. In addition, like not everyone sort of meets the criteria or the need for that level of intensity of service. So we also have an incredible host of intensive outpatient programs as well that actually focus on a lot of the same things we're talking, not so much exposure therapy per se, but providing trauma-informed care, providing psychotherapy to help with trauma symptoms, substance use disorder, anxiety and mood. There's a youth program. So there's a ton of people are served through our outpatient services as well.
Yeah, absolutely. That's why whenever people reach out, I always encourage them to contact admissions or referrals, because then they can be placed in less severity, further severity, like whatever their predicament may be. But we always encourage people to contact the professionals, much like yourself, for these types of conversations. That was actually a good majority of our questions was talking about placement of programming if they're not located in Peterborough, if they have access. So I think that covers a lot, which is good. But we can get to a little bit more of the specific questions too. So this is a situational question. I manage a drug treatment court. Almost all of our participants have PTSD or CPTSD. What types of issues do you typically use exposure therapy for in those suffering from a substance use disorder?
Yeah, I mean, what we know is that there is a huge relationship between trauma and substance use. So not to say that they automatically go together, but many people who struggle with a substance use disorder have been exposed to trauma. It doesn't necessarily always mean they meet the criteria for PTSD. But to answer that question specifically, A lot of these techniques, this was not a technique developed specifically to target PTSD. It's to target the avoidance that comes with severe symptoms of things like PTSD, like anxiety, like OCD, like social anxiety. I actually saw a question listed there around, I saw that a few times around social anxiety. And the idea is that you are exposing them to those things that those social situations that they fear, but starting with, like, perhaps it's just talking about that social interaction. Perhaps it's just being in the presence of others socially. And you would slowly sort of work towards that. For alcohol, let's just use alcohol use disorder as an example. I mentioned it before. Sometimes it's, they develop really great insight into their illness, really great sort of relapse prevention strategies, but sometimes they're not quite always prepared for how they're going to be able to handle something like having to go to a chiropractor appointment that is right beside a liquor store, and maybe not prepared for the intense distress that may come with that, or the temptation to sort of resort back to strategy or to maladaptive coping strategies that they've used in the past. So we've actually used exposure therapy, and I would say more exposure-based modalities. I wouldn't necessarily always call it therapy, to identify, okay, obviously supported. I'm not going to let you walk into the liquor store right now, but we're going to actually walk by and employ the strategies we're learning around distress tolerance and relapse prevention and all those strategies we're working on, to have you be able to do that in the community, so that you're not driving completely around the other side of town or choosing a different chiropractor provider because they happen to be beside a liquor store. That those are things that are likely very unavoidable in the community, and how can we help you sort of do that? So, like, for example, we had someone once who used to be an incredible bowler, and was competitive in bowling, and has really had to kind of take a step back and not actually engage in that really important activity to them that was part of their sort of social and emotional well-being, because now most bowling alleys serve alcohol. So being able to work up to actually playing what do they call it? Not a round, a frame. Is that what it's called? Play a frame, or bowl a frame of bowling, in the presence of somewhere in that environment that serves alcohol, or the presence of people drinking around them. So very far into the hierarchy, if we feel as though it's safe and clinically appropriate, we've taken our clients to Blue Jays games, for example, in Toronto, where it is unavoidable that people will be consuming alcohol. And of course, that's done in an incredibly safe environment. A lot of people in various stages of recovery will say that part of my recovery is I will never put myself in that situation again. And we absolutely respect that and will encourage that. We are very much an abstinence program, but you have to balance that with, like, baseball is incredibly important to me, and I have children who play baseball, and sometimes the parents have a beverage after the game, and I want to be able to participate in those activities, but not actually participate in that behavior that's and the illness that's really kind of disrupted my life. So those are kind of examples of ways we would build some of those activities into their hierarchy if it fits with their clinical presentation. That's the key.
For sure. And I think a root of that too is that everyone's journey is so, like, specific to them, right?
Yeah.
Like you said, it might work for somebody, it might not work for somebody else. So just working with your clinical team or with your support network, and kind of realizing what is a potential trigger and what is not, and then just acknowledging the type of situation that is comforting for you.
Yeah. What I will I saw a lot of questions. I'm just looking at the time, but I saw a lot of questions about, okay, this is great. The gateway exists. Great work you're doing. Obviously, we know it's not enough, and if we could replicate what we're doing everywhere, we would be doing that, and that obviously would be the goal. But I can see that there'd be people where either they feel as though I want to access this in the community, I want to be able to kind of do this type of work. My suggestion would be seek out either seek out supports through something like an OSI clinic, like an occupational stress injury clinic. or look for particularly, there are a lot of occupational therapists in particular who specialize in the delivery of exposure therapy, or psychotherapists in the community. Those would be the professions, like if you're looking for someone in your home environment or your home community, reach out to some occupational therapists, for example, and ask, do you provide exposure therapy for PTSD or for OCD, and so that would be a really practical kind of example I'd suggest, because OTs, just by nature of the work that they do, often get incredibly sort of hands-on and involved, and will do work actually in the community. It doesn't mean that people can't do imaginal exposure therapy in other forms, or like imagery-based ones, but if we're thinking in vivo exposure would be helpful for a client you're supporting or for yourself, I'd really encourage you to seek out support through someone like an occupational therapist, if that's what would be helpful.
Yeah, no, that's great. I think that's a great tangible resource for a lot of people.
Mm-hmm.
Like if treatment is something that's not available to them, then I think that's a great step, at least, to take towards that. And I think too, going off of this conversation, like with PTSD and substance use disorder, EHN Canada specializes in concurrent programming, where we don't just address one and then move to the other. We're able to simultaneously treat those. And as Shawn mentioned too, like you can really identify the root of the substance use disorder or the root of the like trauma, whatever it may be. So it's something definitely worth exploring. And it's something that we're getting towards talking about a lot more, is concurrent programming, which I think is super, super important to acknowledge with us. And then it looks like we have time for one more question. You know what, we have two. We can do two. Have you ever accepted therapists as clients for this type of treatment?
So thankfully, I think one of the things that's come with sort of a breaking down of stigma is that the definition of particular terms like first responders has really grown. So what we do include as sort of a first responder, not only just healthcare workers, even that definition of a healthcare worker has really broadened beyond the narrow sort of scope and the incredible practitioners like nurses and doctors. So of course, those would be included in the healthcare worker designation. But we've included healthcare workers in the definition of first responders as well, because if you think of an emergency department, for example, in a small community or a city, the level of sort of crisis and unsafe sort of situations that they're often exposed to absolutely has them fulfilling the role of first responder often, and that is not limited to just nurses and physicians. There's often, you know, child and youth workers, case managers, social workers, you know, respiratory therapists, lots and lots of other, you know, even just triage staff that we haven't treated many people outside of nurses. I will admit, we have only been open since July of 2021. I mean, nurses make up the bulk of our healthcare system, so that would be, it makes sense that they would be who we treat most often. But we absolutely would not withhold treatment from say a social worker working in a crisis department in a hospital or a mental health hospital or something like that. So our definitions are rather broad.
Perfect. Yeah, thank you so much. And then just kind of a final question too. They're asking for differentiating between PTSD and CPTSD. If you could elaborate further on that.
Yeah, so I mean that might be kind of a longer one, but essentially CPTSD is considered to be complex PTSD, where PTSD is PTSD. So I feel like I wouldn't really do it justice to sort of just gloss over that. But perhaps what we could do is in the resources, we could offer a little bit of like a definition and exactly sort of what the key difference is. Typically with complex PTSD, just to be very, very brief, it includes sort of childhood experiences and sort of adult experiences, that it's typically people who've exposed to multiple different types of traumas, and that sometimes their symptomology can present in slightly different ways than your typical sort of PTSD diagnosis, which again, we can provide a bit more information just so that I don't have to be so glossed over in my in my response.
100%. Yeah, we can include follow-up resources pertaining to this.
Perfect.
For sure. And yeah, like you said, it's not doing justice to the whole definition, but we'll for sure include a follow-up resource for that too.
Absolutely.
But that unfortunately is our time. I want to thank you so much, Shawn, for your time and for your information, your knowledge, your expertise on this topic. To reiterate everybody's comments in the chat, thank you. And this was a great webinar, and I think it was insightful for us all. I know I learned a lot, and I work for EHN, and I learned so much about the programs that we offer, which is fantastic. To everyone in the chat as well, we will be sending out a recording of today's session, along with additional resources and a copy of today's slideshow presentation in a follow-up email sometime mid to late next week. And it'll include your CEU certificate today for your attendance. And thank you so much, and we will see you soon. Take care.